residency at the University of Virginia in 2011. He's a Louisville native and he has provided primary care in his hometown for over 14 years, focusing on personalized care and long-term patient relationships. Thank you, Dr. Anderson.
Thank you. Can everybody hear me okay? I guess you can't answer that very well.
We can hear
Honored
you.
to be able to talk to you all. This is something new for me, so bear with me. I was given a broad topic of diabetes and type 2 diabetes in general, so it was hard to kind of find out what would be most useful over the next 30 minutes. Tried to focus on things that would be useful that we can start hopefully implementing in day one to improve patient outcomes. So let me switch over to the presentation itself and we'll get started. So learning objectives for today. We're going to discuss metabolic syndrome, how we are broadening our understanding of metabolic syndrome and novel strategies to manage it. We'll discuss proper diagnosis of type 2 diabetes. Likely won't be able to get to continuous glucose monitoring as we've kind of narrowed down the talk to get it under the time frame. But if I get to that, we'll certainly go over that as well. Wanted to introduce you to a patient that I kind of based this case study off of. He's a patient of mine I've taken care of for a long time. He has a lot of complex health issues, none of which are overly unfamiliar. He has hypertension, hyperlipidemia, type 2 diabetes, history of heart failure with preserved ejection fraction, chronic kidney disease, severe obesity with a BMI of 41, sleep apnea, erectile dysfunction, anemia of chronic kidney disease, knee osteoarthritis, and lumbar stenosis, which greatly limits his ability to get day-to-day activities. And he often comes and talks to me about his chronic fatigue and dyspnea and his difficulty with his daily life. Medications for him include aspirin, ARB, carvedilol, chlorothalidone, spironolactone, and atorvastatin and tamsulosin. I didn't include his diabetes medications at this time because I wanted to talk about some of our options. And seen him on the exam that's on this day, nothing atypical. He does have significant central adiposity. He has some pitting edema, which is chronic for him, 1+ pitting edema with 1+ pedal pulses, exhibits an antalgic gait and has trouble getting up from his chair, has trouble getting up on the table, which certainly exemplifies his difficulty with his day-to-day activities. Key lab work includes his A1C of 8.9%, so diabetes that is not well controlled. Stage 3B chronic kidney disease with a creatinine of 1.69 that has been stable for him. Mildly elevated liver enzymes, including his ALT and AST being elevated at 65 and 47. Lipid profile shows well-controlled LDL cholesterol on statin medications. Hemoglobin, platelet counts are stable as well. Platelets are normal. And he has evidence of microalbuminuria with a microalbumin creatinine ratio of 98. So very common patient for us to see in our practice, and he was an excellent example of a person that certainly has metabolic syndrome, but a good example of some of the sequelae that comes with and from metabolic syndrome. Just as a quick reminder, metabolic syndrome is the presence of 3 or more of the following: central adiposity with increased waist circumference, elevated triglycerides, reduced HDL cholesterol, elevated blood pressure, and an elevated fasting plasma glucose. Recently, the American Heart Association suggested that we extend our thinking of metabolic syndrome to also include the cardiovascular system and renal system. The point of this is that it's hard to talk about metabolic syndrome without also recognizing the direct impacts on cardiovascular and kidney disease. They further risk stratified the thinking as far as metabolic syndrome and what they called CKM syndrome. The stage 1 being just being excess fat. We know that there's metabolic changes even before there's any evidence of clinical disease. And they further go through the staging, and then the end stage is recognizing clinical CVD, heart attack, stroke, heart failure as well. And this tends to be the end stage, the most likely cause of morbidity and mortality with these patients. A subsequent paper expanded on this, and it was a really interesting paper worth looking at, the cardiovascular renal impacts of metabolic syndrome, but also wanted to emphasize the importance of recognizing hepatic disease, fatty liver disease. So in this slide, they discuss the different aspects of metabolic syndrome with hypertension, dyslipidemia, and so on, including the importance of recognizing the role that the fatty liver plays as well. And the paper also went on to discuss other hormonal changes that often goes along with metabolic syndrome, including PCOS and hypogonadism in males. Part of the emphasis of this paper was to show that, again, it's hard to talk about metabolic syndrome. It's hard to talk about diabetes without talking about metabolic syndrome. It's hard to talk about metabolic syndrome without thinking of the end organ damage, and especially with the heart, the kidneys, and the liver. Um, One certainly affects the other. When the liver starts to be affected with increased fibrosis, that can have impacts on the heart and kidneys and vice versa. Before any end organ damage can be recognized, we start seeing these inflammatory markers, increased cytokines that are coming from dysregulated fatty tissue. So there's hormonal and chemical changes happening before there's any evidence of clinical disease. First recognition typically is when we start seeing the manifestations of direct metabolic syndrome with the elevated blood pressure, blood sugars. But underneath that story, where there's the chronic inflammation, increased oxidative stress, the reactive oxidative species, increased sympathetic nervous system response, increased aldosterone response. And these in turn start to change the organs that we care about. Now, whether we're talking about liver disease, kidney disease, or diabetes, or even just metabolic syndrome, the leading cause of death for these patients continues to be clinical ACVD. So heart attacks and stroke and cardiovascular death. So it's important to keep that in mind. And a lot of the goals of current therapy are not only to help preserve the end organs, but also to lower that ASCVD risk. And certainly, this paradigm also gives us an idea of what to think about with our own patients, including the patient I presented today. So currently, modern diabetes care is no longer about just keeping the blood sugars under control. It's about an integrated, holistic patient care, a holistic management strategy. There are shared mechanisms that link diabetes, heart disease, kidney disease, and liver disease, and that's what our current care should be focused on. We've had interesting changes in options with diabetes, especially with the SGLT2 inhibitor medications and the GLP-1 receptor agonist medications. And there's multiple studies that have been coming out over recent years looking at the benefits in heart attack, stroke, heart failure, chronic kidney disease, and liver disease as well. And so our goal is to improve these outcomes across all these diagnoses. So first off, wanted to focus on the GLP-1 medications and the closely related GIP-GLP-1 receptor agonist medications. These are medications that stimulate hormone release, incretin-based hormone release from the intestines. It affects multiple areas of the body, including the pancreas, resulting in glucose-dependent insulin secretion. The glucose-dependent portion is important because it means we don't get increased insulin secretion unless there's carbohydrates present. So the risk of hypoglycemia is very, very low in these patients, which is wonderful. It suppresses glucagon, slows gastric emptying, reduces appetite, and as most of us know, promote significant weight loss as well. We have options with daily or even weekly injections. A lot of the recent studies have focused on the medications that are presented and are given in weekly injections. And there's also an oral semaglutide that has now been approved and available as well. Other than the notable decrease in weight loss, there's also a very significant reduction in A1C. Typically, we can see in the range of 2 to 2.5%. So it has potent ability to reduce your A1C. Weight loss can be in the range of 5 to 6% for most GLP-1 medications, but for the GIP-GLP-1 medications such as tirzepatide, it's more in the 10 to 12% range. So significant weight loss is a benefit. GI side effects remain the most prominent concern, is the most common reason we have to stop these medications. It's dose dependent, so we want to start at a low dose and gradually increase the medications as the patient tolerate. There is a risk for gallbladder disease. There's a potential risk for pancreatic disease as well. More recent studies looking at the pancreatic disease risk did suggest that this may not be a causal relationship, but it's still something that we should keep in mind. Studies looking at semaglutide in particular showed increased risk for diabetic retinopathy. The current thinking is that this is related to the rapid reduction in blood sugars that results in increased retinopathy. So patients that have a long history of diabetes or might be increased risk for retinopathy, getting a baseline eye exam is typically recommended and repeated after about 6 months to make sure that there's no concerns in that area. There is a contraindication for medullary thyroid cancer, personal history of medullary thyroid cancer, but not papillary, which is the more common thyroid cancer. Also, contraindication if there's a family history of MEN2. This was seen in rats, but has not been seen in human studies so far. And as a precaution, it's generally recommended to hold the weekly GLP-1 medications 1 week prior to surgery. With the gastroparesis, there's a concern for increased aspiration risk. So moving on to the benefits, thinking of our patient. With our patient with metabolic syndrome and multiple other risk factors, his risk of heart attack and stroke is going to be high. One of the biggest benefits of GLP-1 medications, other than reduction in an A1C and significant reduction in weight loss, is it has significant reduction in heart attack, stroke, and cardiovascular death. There was a meta-analysis that showed an overall 14% reduction in these risk factors, or excuse me, in these concerns in MACE. There's also a 12% reduction in all-cause mortality. More recently, and importantly, there's been a recent study showing a reduction in heart attack, stroke, cardiovascular deaths with the oral semaglutide that's available. So that was the first study to show that the oral drug has cardiovascular benefit as well. GLP-1s do have some potential benefits in heart failure patients. It improves heart failure symptoms and exercise capacity, but doesn't seem to have an impact on risk of hospitalizations or other outcomes. There's also potential benefits with GLP-1 medications with chronic kidney disease, decreased risk of progression of chronic kidney disease. It's unclear if this is an actual renal protective effect or if this is just related to improved control of A1C and weight loss. And one of the more exciting changes that's come in recent years is that GLP-1 medications have been shown to have benefits in fatty liver disease, which is now called MAFLD and MASH, metabolic dysfunction-associated fatty liver disease. So medication, we previously didn't have much as far as options pharmacologically for dealing with these conditions. And they looked at patients with established MASH and with significant fibrosis of at least stage 2 disease. And there was a reduction in overall inflammation in the liver and even reduction in fibrosis as well. So previously, we didn't have a lot of good options other than exercise and diet. And now we have some pharmacological options to help our patients that also helps their diabetes. They've been looking at other potential uses with the GLP-1, improved outcomes or improved disease severity rather with obstructive sleep apnea and tirzepatide. PCOS has shown some improvement in menstrual regularity and spontaneous pregnancy rate. There's even been some studies looking at potential benefits of GLP-1 medications on substance abuse, Alzheimer's, and Parkinson's, but these studies are still certainly ongoing. So GLP-1 medications overall, excellent at reducing ASCV risk and potentially has other beneficial aspects to it as well. Now, moving on to the SGLT2 medications, this is also potentially an excellent choice for our patient we were talking about. These work differently. They work on the kidney itself, inhibiting glucose reabsorption in the proximal tubule, results in glucose in the urine, tend to see more diuresis related to this as well. There's a more modest reduction in A1C, weight loss, and there's even some blood pressure lowering with it as well. Important to note that SGLT2 medications, since they work on the kidney itself, the GFR matters. Typically, once the GFR starts to drop below 45%, we're not getting much of the A1C reduction benefit from these medications. However, as we'll talk about, the cardiorenal benefits persist even with the reduced GFR. It's recommended to continue SGLT2 medications up to and at the beginning of dialysis because of these potential benefits. Risk with the SGLT2 medications, risk of genital mycotic infections. There is some potential risk for urinary tract infections. A rare but important risk of diabetic ketoacidosis, volume depletion, since it does cause more diuresis, has to be a concern. Hypotension, there were some early studies that lower limb amputation was a concern. Further follow-up studies potentially did not show this same risk. It's something to be aware of for our patients that might have lower or higher risk conditions for PAD, but something that doesn't preclude using these medications. There's also potential surgical risks. This is related to the risk of DKA, volume depletion, and generally recommended to hold SGLT2 medications 3 days before surgery. And also in other sick conditions, if the patient is not eating well, holding the SGLT2 medication would be a reasonable recommendation as well. Now, moving on to the potential benefits. SGLT2 medications provides a lot of benefits in a lot of different areas. It also has improvement in ASCVD risk, MACE, and cardiovascular death improvements. For example, the EMPA-REG trial that looked at empagliflozin showed a hazard ratio reduction of 0.86 for MACE and 0.62 hazard ratio for cardiovascular deaths. One of the more interesting and exciting areas with these medications is the potential benefits of heart failure. As I mentioned, our patient had HFpEF. Traditionally, we haven't had a lot of pharmacological options for these types of patients. It is shown benefit not only in HFpEF, but heart failure with reduced ejection fraction versus heart failure with preserved ejection fraction. In both of these patients, there's a lower risk of hospitalization and death. The benefit was seen regardless of ejection fraction in initial studies. But furthermore, the empagliflozin and dapagliflozin are now first-line therapies for heart failure with preserved ejection fraction. This is a change. We previously did not have many good options for these patients, at least pharmacologically. And this has shown benefit with or without diabetes, decreased hospitalization rates, functional status, and quality of life. SGLT2 medications are now first-line therapy for HFpEF. It's also standard of care for our reduced ejection fraction patients as part of one of the 4 pillars of good care for heart failure with reduced ejection fraction. So excellent option for these patients. Also, a lot of emphasis on the potential benefits on the kidney. SGLT2 medication, slow kidney progression, reduced protein in the urine, lower risk of kidney failure along with cardiovascular events. Recommended to start these medications with the GFR above 20, helped improve these outcomes. Again, looking at empagliflozin, the use of that showed improved renal outcomes, which would be progression to kidney failure, worsening of creatinine, worsening of albuminuria with a hazard ratio of 0.61. They are looking at using SGLT2 medications in our fatty liver patients as well, our patients with fatty liver disease. They do promote weight loss. They have been shown to improve the metabolic parameters in these patients, but the evidence of direct benefit is still ongoing, and hopefully we'll have results of that soon. So this is a really interesting resource and flow chart. The American Diabetes Association has a standard of care guideline, which is quite long, but really well organized. And this flow chart is in their guidelines in Chapter 9 and kind of emphasizes how we think of different health issues that the patient is dealing with, where our priorities for their care may be, and how does that guide medication options. Typically, with ASCVD risk, if that's the main concern, GLP-1 medications tend to be the first priority. If weight loss is the first priority, the GLP-1 medications do the best at that. Tirzepatide, with the GIP-GLP-1 medication being the best at weight loss. If there's more emphasis on the need to address heart failure or chronic kidney disease, SGLT2 medications become a more significant priority. Lower in the chart, they also discuss options with fatty liver disease as well. Again, GLP-1 medications being likely the best option when that's a significant concern for our patients. Furthermore, they have an in-depth chart that is a great resource to look at as we're wondering, well, which medications do I use for which condition? They even go so far to break down specifically which medication, generic name medication is most beneficial based on your main concern, and is a wonderful resource to have available and look at as everything seems to be changing very, very rapidly in these areas. Got it. So moving on. After considering what we can do for our patients with established type 2 diabetes, this was another patient I took care of and still take care of. This case was roughly 14 years ago. SGLT2 medications were brand new on the market as an option to help avoid need for insulin in some patients, help promote weight loss. This patient was a young lady, 33-year-old female with a history of type 2 diabetes, severe obesity, and albuminuria, PCOS. She had been struggling with her weight for years and unable to lose weight despite diet and exercise. Her diabetes was well managed with metformin, sitagliptin, Lispro, and insulin glargine. I'll digress for just a moment to mention that the DPP-4 medications, like sitagliptin and other gliptin medications, have not been shown to improve cardiovascular outcomes. They seem to be neutral in their effect. So when we're trying to emphasize improved cardiovascular outcomes, DPP-4s would not be probably our best option in those cases. Going back to our young lady, she had a family history of gestational diabetes, several second-degree relatives with type 2 diabetes. With her difficulty with maintaining or controlling her weight, she opted to have gastric bypass about 3 months before presentation, and she had been successful with a 40-pound weight loss and was doing well. Bariatric surgery was so impressed, they stopped her insulin, thinking it would not be necessary. She subsequently had difficulty controlling her blood sugars and restarted the insulin on her own. Her A1C increased to greater than 9% when she presented back to me. We discussed options at the time, SGLT2 medications being one of the newer medication options that we had, and she was interested in trying to get off and avoid insulin if at all possible. So we started her on canagliflozin, sorry. Within 3 days, she presented to the ER with nausea, vomiting, abdominal pain, lethargy. She was quite sick, ended up quickly in the ICU. Her labs, as below, significant for a pH of 7.16 with a significant metabolic acidosis and an anion gap of 28. Her lactic acid was low at 0.7. Interestingly, her glucose was 181. She did have glucose in her urine and ketones in her urine as well. So with this patient, she was started on hemodialysis for the significant metabolic disarray, started on a bicarb drip. She was treated with broad-spectrum antibiotics. The concern is that she was septic with an active infection. Ultimately was diagnosed with DKA. Even though her glucose levels were normal at the time, she was diagnosed with DKA, and with IV insulin, bicarb drip, she had rapid correction and improvement in her symptoms. Now, so what happened? After this patient, I had to think a lot about what was going on. Within 2 months of taking care of this patient and having this outcome, a black box warning was applied to SGLT2 medications for the risk of DKA. Specifically, euglycemic DKA can be seen as well. She was already having significant weight loss. She was at a calorie deficit after her bariatric surgery. Ketone production was probably already increased at baseline, but then we added another medication that could increase the risk of diabetic ketoacidosis. Additionally, she was previously on insulin therapy. That was stopped as she was doing so well with weight loss, and it was felt it was no longer necessary, but she no longer had that support for her blood sugars in her system. So the question quickly became, do we have the proper diagnosis? Now, this patient looked like a typical type 2 diabetes patient. She was morbidly obese, evidence of insulin resistance. But what we've come to find out is she actually had type 1 diabetes. Type 1 diabetes onset in adults is highly variable. Sometimes progression to insulin dependence can be quite slow. It can take years. 40% of new type 1 diabetic patients in adults are originally misdiagnosed. Some characteristics that might make you think that this is an atypical presentation of a person with type 1 diabetes can be their age, potential poor response to oral medications, severe hyperglycemia, catabolic features would be a reason to have her on insulin, irregardless of diagnosis, but catabolic features would be a concern for type 1 diabetes. Absence of being overweight or having obesity, a strong personal history, family history, or autoimmune disease would be a consideration, and also no family history of type 2 diabetes. Important to recognize currently in today's obesity epidemic that obesity does not preclude a diagnosis of type 1 diabetes. First step for this patient, when this is a consideration, or other patients that you are worried about adult onset type 2 diabetes, is evaluate the autoantibodies. There's several to choose from. GAD65 is one of the most common. We see it in about 70% of patients with adult onset type 2 adult onset type 1 diabetes. It's not a perfect test. We can actually see it in some patients with type 2 diabetes as well. So it's generally recommended to have two positive autoantibodies before diagnosing type 1 diabetes in adult patients. Oftentimes, we think about using the C-peptide to see how much insulin is being produced by the pancreas, but this is often not helpful because the C-peptide levels can remain elevated potentially for years, even if the patient has type 1 diabetes. Again, the American Diabetes Association has a slide that kind of helps help you go through this process. Initially, at the top of the slide, we have a patient that might have possibly type 1 diabetes. We test those islet antibodies. As you can see, there's several options. Want to try and have at least two positive before we give them a diagnosis of type 1 diabetes, but that's not always the case. 5 to 10% of adult onset type 1 diabetes are autoantibody negative. So if we're still of concern, we move down and start thinking about some of the other features of this patient. We're concerned about type 1 diabetes. They potentially have other features that are associated with type 2 diabetes, such as obesity, such as insulin resistance. And so we have to decide how to treat them. Our concern is still elevated that insulin may be necessary and that may be appropriate, but also a trial of continued non-insulin therapy, as some of the other things that we talked about earlier, including metformin, may be appropriate. These patients would need to be monitored closely because the risk of DKA and poor control of diabetes would potentially be higher. The recommendation is to check a C-peptide test roughly 3 years after. We're looking for that change in C-peptide. If we see that start to decrease over years and eventually become undetectable, the likelihood of type 1 diabetes is much more significant, and that'll certainly impact medication choices for our patient. The C-peptide levels can remain indeterminate in the mid-range for years, and so checking the C-peptide level every 3 to 5 years in these patients that we have increased concern would certainly be appropriate. If the C-peptide consistently stays elevated, then type 2 diabetes remains the most likely diagnosis. But these are some of the tools that we can use to help guide us when thinking about how to treat some of these patients. Unfortunately, if I knew some of this information earlier on, when I was first making decisions with this woman on how we were going to treat her diabetes, I probably would have considered other options. But I think this was a very valuable and useful lesson. All right. So like I said, I had so much more I could have talked about, but that kind of brings us to the end of our time.
Awesome. Thank you, Dr. Anderson. Let me